Welcome again to the NCLEX Made Simple YouTube channel. Here is where we try to simplify the NCLEX content to make it as simple as possible to help you pass your NCLEX exam within the first attempt and get that United States Registered Nursing license. We also try to demystify the myth that NCLEX is a hard exam. No, NCLEX is not a hard exam. All you need to know is to know your content and do practice questions. In this session, we are going to be learning about multiple sclerosis, whereby we will look at the introduction. I will introduce multiple sclerosis. We define what is multiple sclerosis. We look at the incidence of the disease, the etiology and risk factors. We'll also discuss the pathophysiology of the disease. We look at the clinical manifestations and the management. And then, as usual, we will finish with you taking NCLEX style questions to test your knowledge and understanding. Again, welcome. We start with the introduction. When it comes to multiple sclerosis, it's one of the autoimmune nervous system disease. Remember, we said that autoimmune disorders of the nervous system can attack the central nervous system, which is composed of the brain and the spinal cord, or the peripheral nervous system, which consists of the cranial nerves and the spinal nerves that connect the central nervous system. What is multiple sclerosis? It's a chronic demyelinating disease that affects the myelin sheath of neurons in the central nervous system. That is what we call multiple sclerosis. By definition, we are saying that it's a chronic demyelinating. That means it leads to the destruction of the myelin sheath disease that affect the myelin sheaths of neurons in the central nervous system. And it will affect the myelin sheath, but the axons will be intact. Remember that. On this diagram, you can see the structure of the neuron. I'll use an arrow. You can see we have the nucleus there at the center. We have the dendrites, which are protruding. Then we have the soma after the nucleus. You can see we have the axon. The axon, you can see the one I'm pointing with the arrow. Then we have the myelin sheath. Then we have the strand cells inside the myelin axons, the axons. Then we have the nerve heading. That's the structure of the neuron. Incidence of multiple sclerosis. Incidence 1. Its onset occurs between 20 to 50 years of age. The second point I would like you to know is that women are more affected than men. Another point to note is that it mostly affects the whites more than Hispanics, blacks, or Asians. It is also prevalent in colder climates of North America and Europe. Another important point is that its development is thought to result from genetic predisposition plus an environmental trigger. Remember those. I have said about the incidence. Its onset is mostly from 20 to 50 years of age. Women are more affected than men. Whites are more affected than Hispanics, blacks, or Asians. It's most prevalent in colder climates of North America and Europe, and its development is thought to result from a genetic predisposition plus an environmental trigger. About etiology and risk factor, the exact cause is unknown. Remember that. Although most theories suggest that multiple sclerosis is an immunogenic viral disease, mostly associated with Epstein-Barr virus. Some of the risk factors that can make a person develop multiple sclerosis, we have age, most of the time between 20 to 40 or 50 years of age. We have sex, women are more affected than men. We have family history, that is genetic susceptibility. If a member of the family, let's say like a father, had this disease, it is very likely even the children might develop multiple sclerosis. Certain infections, especially with Epstein-Barr virus, that is it's a virus which can lead to immunogenic viral disease. We have climate, more in cold climate areas. Remember, we have seen mostly in Europe and North Americans. We have certain autoimmune diseases, higher risk with thyroid disease, type 1 diabetes mellitus. Mostly the patients with these autoimmune diseases are also very highly likely to develop multiple sclerosis. Smoking also predisposes one to develop multiple sclerosis. Stress, fatigue, all these are predisposing factors. Physical injury is also another predisposing factor which can make one develop multiple sclerosis. Pregnancy is also a risk factor which can predispose one to develop multiple sclerosis. And in pregnancy, this one may may be relating to stress due to riba or puerium. Remember that. Pathophysiology, this is very important. We will be trying to look at what leads to multiple sclerosis. Yeah, we see that etiological factors, or what we call the risk factors, they will cause an autoimmune process in which the T cells and the beta cells are activated from the peripheral circulation and migrate to the central nervous system. Remember, the CNS, we think it's composed of the brain and spinal cord. When this happens, that one leads to production of inflammatory cytokines and reactive oxygen species, which will cause an inflammation. Activated T cells and beta cells will cause demyelination, that is the destruction of the myelin sheath, and destruction of oligodendrocytes. Oligodendrocytes, those are cells which produce the myelin. Remember that. Causing formation of handbrakes. That one will lead to scarring and destruction of the sheath, and that one will prevent myelin production, damaging axon, causing through transmission and permanent loss of function, leading to multiple sclerosis. That's how that disease develops. Etiological factors, those are the risk factors. They cause an autoimmune process in which the T cells and the B cells are activated from the peripheral circulation, and they will migrate to the CNS, that is in the brain, and the spinal cord are the ones which make the central nervous system. That will lead to production of inflammatory cytokines and reactive oxygen species, causing inflammation. The activated T cells and beta cells cause demyelination. Demyelination is the destruction of the myelin sheath and the destruction of oligodendrocytes. Oligodendrocytes are cells that produce myelin, causing formation of handbrakes. That one leads to scarring and destruction of the sheath, and that one will prevent myelin production and damaging the axon, causing through transmission and permanent loss of function. All that will now lead to multiple sclerosis. That is basically what happens in pathophysiology. What are some of the clinical manifestations of the disease? Clinical manifestations, they vary between clients. They vary from a person to person, depending on the location of the lesions in the central nervous system. We have cerebellar signs. Cerebellar signs, a patient might exhibit nystagmus, that is involuntary high oscillation. A patient can also present with ataxia, dysrhythmia, or dysphagia. Dysphagia is difficulty swallowing. Motor signs, a patient can experience weakness or paralysis of the ribs, trunk, or end. A patient can also experience diplopia. A patient can also have scanning speech, and a patient will also have muscle spasms. That is spasticity of muscles that are chronically affected. That is what we call muscle spasms. Sensory signs, a patient can have numbness, tingling, neuropathic pain, and also paresthesias. Patchy blindness can also occur, or what we call scotomas. A patient can also experience blurred vision. A patient can also experience vertigo, tinnitus, decreased hearing, and also what we call chronic neuropathic pain. A patient can also present with radicular, or what we call nerve root pain in the lower thoracic abdominal region. A patient, this is also very important for the NCLEX, a patient can present with what we call Hermite sign, which is a transient sensory symptom described as an electric shock radiating down the spine or into the ribs with flexion of the neck. That is what we call Hermite sign. And we are saying that what is Hermite sign? Is a transient sensory symptom described as an electric shock radiating down the spine or into the ribs with flexion of the neck. Remember that. We can also have emotional problems, and here a patient will experience fatigue. It's mostly associated with energy needs, anger, euphoria is happy moods, and also emotionally a patient can be depressed. We also have cognitive problems when it comes to clinical manifestation, and here a patient will present with problems in short-term memory, planning, word finding, and also visual perception. Another very important signs and symptoms when it comes to clinical manifestations of the disease is bladder and bowel control. That one is also affected. Bladder and bowel control are affected. And when I talk about bladder and bowel control, I'm talking about urination and defecation. What normally happens, a patient can have spastic bladder. What is spastic bladder? That one is an uncontrolled bladder contraction, which results in urgency, frequency, and incontinence. spastic bladder. It's uncontrolled, uncontrolled bladder contraction, which resulting in urgency, frequency, and incontinence. A patient can also present with flaccid bladder when it comes to bladder bowel control, which is also affected. And when I talk about flaccid bladder, that is whereby a patient has decreased or absent sensation of the bladder. There is decreased or absent sensation of the bladder, which will cause urinary retention. We also have constipation. Constipation will be more common than fecal incontinence. Another common clinical manifestation is that patient can experience sexual dysfunction. And when I talk about sexual dysfunction, I'm talking of symptoms such as erectile dysfunction, decreased libido, and also painful intercourse. I'll now proceed and we look at diagnostic evaluation. How do we diagnose this disease? Of importance, you should know that there is no definitive test for multiple sclerosis. There is no definitive test that we can do that can directly lead us to diagnosing multiple sclerosis in a patient. However, you can take a detailed history of episodes of neurologic dysfunction from a patient, obtain a detailed history, do also physical examination, That one can help us to diagnose multiple sclerosis. And some other tests that we can do, they include cerebrospinal fluid evaluation. What we do here, we check for the presence of immunoglobulin G antibody, or what we call oligronobodin. We say evoked potentials of optic pathways and auditory systems are assessed for presence of throat nerve conduction. We can also do magnetic resonance imaging of the brain and spinal cord to determine the presence of multiple sclerosis plaque. We can also do a CT scan, which will help us to detect areas of demyelination, but with less details as by MRI. We now look at how we manage the disease. Management of the disease is also very important. And one thing I would like you to remember is that there is no exact cure for multiple sclerosis. The aim in management of multiple sclerosis is to prevent or postpone the long-term disability. It often evolves slowly over many years. And in management, our goals of care, the goal number one will be to slow disease progression and prevent relapses. That's the goal number one when it comes to management of multiple sclerosis. Our goals of care, number one will be to slow disease progression and prevent relapses. Our goal number two will be to maintain or improve muscle strength. Our goal number three will be to maintain urinary continence. And our goal number four is health and lifestyle modification. So our goals of care are four when it comes to management of multiple sclerosis. And we have seen our goal number one is slow disease progression and prevent relapses. Goal number two is to maintain or improve muscle strength. Goal number three is to maintain urinary continence. And our goal number four is health and lifestyle modifications. Let us now look at the pharmacological management. And when I say pharmacological, I mean management using medications. And here we are going to look at certain medications that we use in the management of symptoms in a patient with multiple sclerosis and what the medicine does. And I'll start with immunomodulators. We have drugs such as beta interferon. That is an example of an immunomodulator. We also have immunosuppressants and monoclonal antibodies. What these medicines do, they slow the disease process and prevent relapses by modifying immune cells. They slow the disease process and prevent relapses by modifying immune cells. The side effects of beta interferon, remember this, will include photosensitivity, suicidal ideation, so monitor for suicide in a patient using beta interferon. We have flu-like symptoms, hepatotoxicity, they cause damage to the liver. When I talk about hepatotoxicity, that's damage to the liver, and possible teratogen, remember that. We also have corticosteroids. Corticosteroids, they are used to manage exacerbations by reducing inflammation in the central nervous system. We have cholinergics. Cholinergics are used in the treatment of flaccid bladder by stimulating contractions. We have anticholinergics. They are used to treat spastic bladder by reducing bladder contractions. We have muscle relaxants. An example of a muscle relaxant is a drug such as baclofen, and is used to treat muscle spasticity. We have also conduction enhancer. Here we mostly use potassium channel blocker to increase walking speed in a patient. That's the pharmacological management of multiple sclerosis. Non-pharmacological management of multiple sclerosis. One, nutrition therapy. Here we give a patient what we call megavitamin therapy, and this can be vitamin B12 or what we call carbaramine and vitamin C. We also put the patient on low fat diet, and we also encourage a patient to eat high roughage diet, a diet rich in fiber to relieve constipation. Another important nutrition therapy, encourage high fluid intake. Other therapies that we can use to improve neurological functioning, which are part of non-pharmacological management, they include physical and speech therapies, exercise, and water exercises. All these are non-pharmacological management. Surgical management of multiple sclerosis. Here we can do something we call deep brain stimulation. If other options are found, then a device is implanted that stimulates an area of the brain in case of severe tremors in the ribs. We can also do implantation of a drug catheter or pump, whereby a catheter is placed in the lower spinal areas to deliver a constant flow of a drug like baclofen. Remember, that one can only be done surgically. These catheters can only be implanted in a patient surgically. And we use baclofen in cases of severe nursing management. Here we come up with nursing diagnosis that our patient can have. And the first nursing diagnosis we can come up with in a patient with multiple sclerosis, they can have impaired urinary elimination pattern related to bladder dysfunction, as evidenced by low output and acute pain. And some of the interventions that the nurse we can do here is to assess the skin for incontinence-associated dermatitis with each voiding. We can also maintain fluid intake of 2,000 ml per day. Encouraging the patient to toilet every 2 hours. We can also do a scan of the bladder for post-voidal residual volume. And if PVR is more than 100 ml, we can catheterize. The patient. Another nursing diagnosis we can come up with for a patient with multiple sclerosis is impaired elimination pattern related to immobility and demyelination, as evidenced by disturbed bowel movement. I have seen impaired elimination pattern related to immobility and demyelination as evidenced by disturbed bowel movement. Some of the interventions here we can do as a nurse. We assess for normal bowel movement. We can administer suppository as advised by the physician. We also teach the client to consume high fiber diet and at least 2,000 ml of fluid. Another nursing diagnosis we can come up with is fatigue related to increased energy needs as evidenced by facial expressions of clients. Some of the interventions here we can do: keep the environment cool, provide mental support, plan for rest periods during the day. We also facilitate sleep by reducing nighttime interruption, noise, and lights. We also come up with another nursing diagnosis of impaired physical mobility related to weakness, contractures, spasticity, and ataxia, as evidenced by pain in muscles and verbal experience. And some of the interventions we can do: we assess the degree of muscle spasticity, stretch muscles, and perform range of motion exercises. We can also administer antispasmodics as ordered. We can also position the patient in neutral alignment. We can also consult with doctor for sprints. Another nursing diagnosis we can come up for a patient with multiple sclerosis is situational self-esteem related to loss of independence and fear of disability, as evidenced by irritativeness and facial expressions. Some of the interventions we can do here: we assess for depression and any related treatment. We assess for client problem-solving strategies. We also evaluate client support system. We also provide experience that increase the client's autonomy. Some of the health education or health teaching we can do to a client: teach them to avoid extremes of heat and cold, teach them about how to use the medications and side effects of the medications. Also, teach them that during periods of immobility, they can do deep breathing and coughing exercises, frequent turning and repositioning. Teach them also to avoid individuals with infections. Encourage them to increase dietary fiber and fluid intake to prevent constipation, and also teach them how to balance rest and activity. Those are some of the health education or health teaching we can do to our clients. We have now come to the end of the multiple sclerosis NCLEX topic review session, and we would like to test your knowledge and understanding of the topic by you doing these NCLEX style 10 questions. Kindly go through them slowly and run from the rationales given and the answers that are there. Thank you for being with us through this topic review. I'd like to pass my gratitude to you all for finishing this topic with us and going through the NCLEX style questions. I hope you have all learned something from it, and kindly we would encourage you to subscribe to our YouTube channel, NCLEX Made Simple, so that you can be getting notifications whenever we do an NCLEX review topic, and we hope to see you in our next video.